And now introducing the Pacific Council's Director of Strategy, Nastasha Everhart.
Hello, everyone. Welcome to today's event, COVID-19 and Immigration at the U.S. Mexico Border. This event is taking place as part of a three-part series designed to spotlight U.S. Mexico relations in the first 100 days of the Biden administration. We're grateful to the Pacific Council's Mexico Advisory Committee, who commissioned the first 100 Days Memo, and whose vision makes all of our work on Mexico possible. I know many of you are on the line today, so welcome committee members and thank you. We're also grateful to the Karen Toffler Charitable Trust for helping make our work on global health possible, and to the International Medical Corps for partnering with us on this event and for their vitally important work, both during a global pandemic and otherwise. Welcome, guests of IMC. I see a lot of familiar names on the line, and I would love nothing more than to say familiar faces, but hopefully someday soon. For those of you who I haven't met or who may be new to the Pacific Council, my name is Nastasha Everhart, and as Sumaya mentioned, I am the Director of Strategy here at the Pacific Council. I have the distinct pleasure of moderating today's conversation on issues at the nexus of immigration and the COVID-19 pandemic. Joining me today are Essey Workie and Scott Lillibridge. Essey is a Senior Policy Analyst at the Migration Policy Institute, where she works with its Human Services Initiative. Her work focuses on unaccompanied children, immigrant families, and access to local, state, and federal health and human service programs. In addition to immigration issues, she has a rich background in refugees, asylum, and resettlement policy. Essey previously worked as the Director of Refugee Health and the Director of Planning and Development at the U.S. Committee for Refugees and Immigrants, where she established the National Refugee Medical Assistance and medical screening programs in multiple states. In her spare time, she provides pro bono leadership coaching to She provides pro bono leadership coaching services to immigrants, minorities, and other marginalized groups. On the other hand, we have Dr. Scott Lillibridge, who is the Senior Medical Officer and Director of Emergency Response Operations for the Americas for the International Medical Corps. Prior to his work with IMC, Dr. Lillibridge served as the Director for Health Initiatives for the Texas A&M University System, where he was the Chief Scientist for the university's pandemic vaccine manufacturing enterprise until 2019. A professor of epidemiology, Scott's academic focus was emergency health services, epidemic control, and the use of medical technology in field settings. You know, I can't imagine two better people with whom we could be talking about this global pandemic here a year in. Its effects on migrant communities and what we can and should expect to see at the U.S. Mexico border as we move into the next phase of pandemic response and management here in the U.S. I'm so happy that you both can be with us here today. So Scott, I want to turn to you first to help frame the conversation. What do you see when you look at the global effects of this pandemic? What trends do you see in the health needs of refugees and migrants globally?
Nastasha, thanks. I wish my mother was here to hear that introduction. Thank you. You're so kind. And at any rate, well, let me take something that's really big, a global pandemic, move it to the United States and right down to the border in terms of the issues we're dealing with. First of all, we don't get these global pandemics very often, fortunately. International Medical Corps is working in 30 different countries. A small fraction of the 181 or so countries around the world, but the issues are rather ubiquitous. We have disruptions of healthcare, transport, borders, spot shortages, difficulty in obtaining pipelines of protective equipment and so forth. And this has really slowed down the world economy. And a lot of the lower socioeconomic countries have really felt the pinch on that. In the United States, we're not immune. It's ironic that a country with only 4.25% of the world's population would have 20% of the cases, but we are highly mobile. Our state government and federal governments are highly fragmented, and we have had at least 3 waves of coronavirus. So we stand now at about 29 million cases with a near-term mark of 500,000 deaths. And we are looking optimistically as this latest trend goes down at a time when vaccine is moving out into virtually all states and territories and beginning to percolate around the world. It is amazing to think of how much my life has changed in the past year. I have started on this trek of COVID response about 12 months ago, and we have been through the hotspots of Chicago, New York, Detroit, South Texas, Los Angeles, Puerto Rico. And it's ironic that the epidemic has peaked at different places at different times. However, we are finally, I think, moving forward and beginning to see some effects of herd immunity. Let me tell you what this means means along the border and how I kind of see this moving here in the United States, particularly around border health issues. In South Texas, where we have our Texas A&M has its Healthy South Texas portfolio, it moves from virtually El Paso all the way to Brownsville. There has been a complete disruption of some of the primary healthcare activities as we've been eclipsed with concern and programming around COVID. We see at-risk populations that have pre-existing conditions of obesity, hypertension, overrepresented in mortality rolls in hospitals, and we are finally beginning to recover in South Texas when we were hit by the ice storm, and we're just getting back on our feet for those kinds of things. Let me kind of relate this then as I move to Central and South America, because we've been watching this closely. In Mexico, there's been pretty clear to a lot of people that Mexico goes up and down with the United States. When our peaks are high, their peaks are high. We are linked not only by trade, but by a common border, and infectious disease doesn't really respect borders. So we have some interesting phenomena. Now, let me go through a few countries in Central and South America just to kind of whet your appetite. Mexico is going to be dealing with 4 or 5 different types of vaccines as they roll out. These have different follow-up requirements. They are different countries, different origins. And it just adds to a complexity of moving public health measures into a country perspective, and for us working with other countries and so forth. Colombia has recently done something really quite interesting for migrants and refugees. On February 8th, they opened up a new ruling to bring migrants and refugees into the national health system. This was really a bold move, which means that they are now integrated and in line for vaccination and healthcare, just like anybody else in Colombia. A real improvement and a fairly bold step. If you look at other countries like Brazil, that's had high rates. It's interesting to look at some of the lessons learned from Brazil. One being, not only is the United States subject to high rates of COVID, but so are other countries such as Brazil. We see some of the similarities in messaging and implementation and strength of public health. And it's important to note that Brazil is one of the few countries that make and manufacture vaccine in South America. I think this will pay dividends in the long run. Let me just emphasize a few things on migrant health that, as a health officer, that I look at, and that these are things that come up time and time again. We have seen these play out and be detrimental. There have been some penalties for health services for non-citizens. That has discouraged healthcare access. Migrant communities have limited interaction to begin with, so this has not been well received. In terms of being able to follow up, leaves many of these communities confused on the guidance. It erodes trust. And the initial phases of the CARE Act really impacted and addressed a lot of the hospital needs, but didn't address the fee for service for physician services. The next area that I wanted to mention and these are really subtle things that affect these populations. while we have emergency services and we have open door policies for acute care, many COVID signs and symptoms are less than emergency in orientation. They may not qualify for admission, so that it makes follow-up and ongoing care impossible if you're using the emergency room as an episodic healthcare delivery system. Migrants and refugees tend to be low-wage workers in many areas, and they can't miss work, so they have to go to work when they're sick. So there's no provision to continue to subsidize and help some of these communities. And these are all the things that we have to address. In closing, let me just mention on some of the migrant health pillars or refugee health pillars that are really important as we look at migrant health and clinic work and activities along the U.S. Mexico border. One is, a focus on primary care. I can't tell you how important it is to have good access to primary care with follow-up and some continuity of ongoing services. Second, migrant health doesn't work along the border, at least as well, without community outreach. Without that public health outreach, we just don't do the follow-up and early intervention that we need, particularly with chronic disease. A number of the donors have begun looking at intertwining mental health with primary care because they didn't get the outcomes that they needed for hypertension, diabetes, without the inclusion of some mental health component. And last, we don't lose our focus on communicable disease. We're still looking at HIV, TB in these populations, but some continuation of essential medications. So those are sort of the pillars of migrant health that we work on a daily basis. Those were some of the migrant health issues that really emerged during the last 12 months of this epidemic. And with that, I think I'll just turn this back to my colleague and we'll just stop here. Thanks.
Essey, do you want to add some comments to build on Scott's framing?
Sure. I think one important point to keep in mind here with everything that Scott has shared is that the populations we're talking about are really the same people, whether they're on the Mexico side of the border or the U.S. side of the border, whether they're refugees in camps around the world or refugees that have been admitted to the U.S. at the invitation of the U.S. government. So that's one point that I'd like to emphasize perhaps throughout our conversation today, that there really is a stream through the different phases of migrants' journeys.
A good point.
Thank you both for your framing remarks. I'd like to start our dialogue more formally by talking a little bit about both COVID and immigration in the Biden era. So my first question is for Essey. As President Biden starts to roll back Trump's immigration policies, experts are monitoring the southern border for, and to some extent we're anticipating, so-called migration surges. Meanwhile, the Biden team has also recently released its COVID strategy, of course, and that has smarter testing, faster vaccinations, and importantly, health equity as cornerstones. So my question to you is, how do you see the Biden administration's immigration and COVID-19 policies impacting one another? And what can we expect to see in the next few months as both start to roll out?
Absolutely, Nastasha, thank you for that question. And if it's all right with you, I think I'll just take a step back to share some of the things that we've been seeing at MPI when it comes to immigration and COVID-19 and the impacts of the pandemic on the population. Earlier on, Scott mentioned that there are over 500,000 people in the US who've passed away from the pandemic. So clearly it's something that's impacting all of us, whether it's through deaths or the adjustments that we've had to make to life in the last year or so. And I think, speaking to your point about equity, which I'll dive into a little bit more deeply in a few minutes here, I think what the pandemic has shown us in the US is that the existing inequities, particularly around marginalized groups, has been exacerbated by the pandemic. And that includes, of course, immigrants of all backgrounds, including folks that have crossed the southern border. I wanted to highlight 7 impacts of the pandemic on immigrants in the US. But first, let me define a couple of key terms that you might hear me use in this conversation. And that is what we mean by Latinx community, migrants, and immigrants. This is important because as I share some statistics along the way, I might be referencing these different groups based on how the data is available. So Latinx, of course, is the most broad term and includes people who aren't immigrants and are members of the Latin American, South American, Central American community. Migrants, in the way that I'm using it, I'm really talking about unauthorized populations or undocumented populations. And then immigrants are, of course, anyone born outside of the US who's now in the US. There are 7 key impacts. One of them I mentioned earlier, the whatever health issues Scott mentioned or mental health issues, the violence and so forth that is at the southern border. As people come in, they're coming with all of that trauma and those chronic conditions. But beyond that, the pandemic itself is causing a really huge health impact. For example, on a national level, we know that people in the Latinx community are dying more than other communities such as white or Asian communities, but not quite as much as African Americans or Native Americans. And then when you think about the economic impacts tied to the pandemic and the health consequences, my colleague Julia Gelat at NPI did a fantastic piece estimating the numbers of immigrants who are at the front line, who are essential workers, as well as those who are losing their jobs because of the sectors that went down as a result of the pandemic. So unfortunately, immigrants are represented at disproportionate levels in both of those groups. So roughly 60 to 75% of immigrants are in the essential workers industries, and many of them also have jobs that were lost, such as childcare or restaurant or hotel, that kind of thing. So they're suffering financially as well as the health impacts. Then comes the issue of housing, which is compounded by economics and health. Since culturally and because of economic reasons, many Latinx communities have intergenerational households, perhaps a lot of people living in smaller spaces, that puts them at greater risk for getting the COVID-19 virus. There's also, we're hearing from the field, some concerns about housing insecurity because of the economic consequences. Then imagine all of these are interrelated and layered upon each other. And of course, we can't forget about the youth. Immigrant youth, particularly in the Latinx community, as well as some refugee communities, are experiencing greater school interruption because a lot of schools are remote, and you have English literacy questions on top of digital literacy questions, creating barriers to access to school. And the older youth are experiencing pressures to choose work over school so that they can keep the whole family going in this time of strain and struggle. Then there's the issue of access to services. A lot of unauthorized or migrant populations don't have access to many health and human services, but even the limited types of services that they do have access have mostly gone virtual. So that brings into focus again the question about digital literacy and digital access, meaning computers, devices, Wi-Fi, internet, and so forth. And then just to close the 7 impacts of the pandemic on immigrant communities, I want to zero in a bit on the interplay between immigration court and the pandemic. Many of you may have heard from the news or from your day-to-day work that certain courts closed for certain populations. Through the EOIR, Executive Office of Immigration Review under the Department of Justice, they divide up the cases between two groups, those that are detained and those that are in the community. For those that were in the community, the immigration courts, many of them closed for several months. And so their cases were pending, and there was a lot of transition. It was very unclear which courts were open, which ones were not, adding to the stress and to the uncertainty of the pandemic and their migration journey. And on top of it all, there's also the issue of the conditions within detention centers and the transmission of COVID within those facilities. Turning now more explicitly to the question that Nastasha asked about the Biden administration and their policies around COVID-19 and immigration. The main overarching theme, I think, about the Biden administration's policies in both areas is a focus on equity and humanity. So we've talked about equity quite a bit already, but I'll dive into it more now. I think it's important to point out that the populations that are coming across the border fall into three categories: single adults, families, meaning parents with their children, and unaccompanied children. My work focuses more on unaccompanied children, so I'll be talking about equity in that context a little bit more. But at a general level, the Biden administration issued the COVID-19 Health Equity Task Force, and they developed a plan, a 200-page plan for how to respond to COVID. One of the sections in that plan focuses on health equity. So they have all of these policies, mainly to undo policies under the Trump era around immigration, and they have all these policies around health equity as well as racial equity. So these three are on parallel tracks, and the question becomes, how do you bring these tracks together? So what kind of cross-learning will happen between the different equity movements? Another question to keep in mind, and this is a bit forward-looking into a crystal ball, if you will, are the opportunities and the challenges that come with this focus on equity and humanity. The opportunities based on the health equity plan, I'll focus on three. One has to do with the requirement for state and local officials to come up with pandemic plans. If immigrants are included in these pandemic plans, then their needs can be addressed as a part of the holistic response for that jurisdiction. If immigrants are not included in the pandemic response, then obviously their needs will be overlooked. Another opportunity is the community health centers, which even unauthorized or undocumented individuals are eligible to access medical care. The plan intends, or the administration, I should say, intends to increase funding to community health centers. So that's promising. Then the plan and administration also indicate that they plan to augment community health workers. So community health workers we'll talk more about a bit later, but they're basically trusted messengers, trusted navigators that do outreach into the community and can really make a difference in vaccine dissemination as well as testing and other safety measures in response to the pandemic. There are some challenges though for the Biden-Harris administration, and that is, again, trying to weave together their commitment to health, equity, and immigration. There are three areas that I'll talk about. One, as I mentioned, is the unaccompanied children and the facilities that they're in. A third is the reopening of MPP. And the fourth is the CDC order, otherwise called Title 42, which gave the government authority to turn people away at the border. And that, of course, was a Trump era policy. When it comes to unaccompanied children, you know, once they're apprehended at the border, they're transitioned eventually to the custody of the Office of Refugee Resettlement. We have been seeing an increase in the number of unaccompanied children entering federal custody and care. And between January 20, when the Biden administration took over, there were 4,020 children in federal custody. As of February 18, just under a month later, there are 6,800. And you may have heard this week that an influx shelter, a temporary shelter, was set up and open for unaccompanied children, partly because of this increase and also partly because of the social distancing that's required as a safety measure in response to the pandemic. The government, ORR specifically, has decided not to use all of their facilities to full capacity, but rather to reduce the number of children in each facility, which means they need more facilities in order to house all of the children. I'll flag a couple of other safety measures that the Biden-Harris administration through ORR has put into place in order to allow the children to come in and be taken care of while mitigating against the virus. And that includes weekly COVID-19 testing of staff and a public health professional and epidemiologist assigned to the Carrizo Springs Influx Center. There are several others, but in the interest of time, I won't go into more detail there. Then when it comes to the MPP cases, so you know from the news likely that people who have been sent back to Mexico after crossing the US border to wait in Mexico for their immigration court proceedings to go through, which can take a couple of years, have now been admitted into the US in a systematic fashion. And the question there is, how are they being tested or treated for the COVID-19 as they're entering US communities? And DHS issued information letting everyone know that they are testing, they're soliciting health questionnaires from candidates, and they're also taking temperature checks to make sure that this is all happening safely. It's a very fine line to walk, but it seems that they're for the task. They're also providing free masks and following other CDC instructions. The last piece I'll mention, and then I'll turn things back over to you, Nastasha, is the CDC order, which I referenced earlier, giving the US government authority to say for public health reasons, we're not allowing everyone in as we did in the past. That is a Trump era policy and it is still in place. And there have been White House briefings where that topic has come up, and that is one to watch. Part of the justification for leaving it in place as of now is because there has been such a buildup over time with folks at the border that in order to allow them in, they want to do it systematically and safely, and they need to build the infrastructure in order to do that.
So you highlighted here several of the challenges at both sides of the border. I'm curious for you both, can you paint a picture for us of what health services and public health conditions actually look like at the U.S. Mexico border 1 year into the pandemic? Scott, I'll toss it to you first.
Yeah, I'll be glad to. You know, it kind of depends on the time of the outbreak, the sort of the stage of the outbreak at various areas. Let me give you kind of what it looks like when we are almost back to normal, or when we're in an uptick in terms of lots of patients. We've had border health activities, particularly migrant health and other activities. When there is a huge uptick, we see the typical overloading of hospitals, refocusing of resources, and towards dealing with the all matters of the epidemic, everything from acquisition of personal protective equipment to medications to bringing in staffing and so forth. It is no different than some other places around the country. The significant change is that we're dealing with populations that are harder to reach. We have to go further out into other areas like colonias or informal settlements. We have to use shoe leather epidemiology, to use that term again, to go out into these communities to do disease tracking, offer services, and so forth. That's when we have a major upswing in terms of the epidemic. When things are relatively back to normal, we see the ebb and flow of the normal refugee and migrant health activities. And you have to pardon me if I conflate these, because as a medical provider, I don't really differentiate between the needs of one group versus another. So in the policy arena and the legal arena, there's a big difference. But in the medical arena, I sort of focus on getting back to business, and that the number one issue, time and time again, on refugee migrant health is really access. There are so many barriers that we are constantly tapping on this access issue. There's economic, there's distance, there's transportation, there is language, and there's cultural barriers, and these go on and on and on. And so if those aren't integral as part of your migrant health, refugee health program, you're really going to miss an opportunity to provide quality care. Over.
And I'm happy to add on to what Scott shared. You know, what really concerns me about what's going on at the southern border is the lack of access to services, as Scott mentioned, and also the infrastructure of services. It's really people, migrants taking care of one another and creating makeshift camps, and sometimes having those makeshift camps disturbed by officials and having to restart again somewhere else. And because there is no formal infrastructure in place, there are issues around nutrition, sanitation, violence, and many other public health concerns. And folks are doing the best that they can. They are organizing themselves. There are, within the migrant population, some health professionals, and we're learning that they're taking on those roles. And there are, of course, many civic organizations that are helping, and even some federal support from Mexico, as I understand, but it's not fully structured and organized and supported, which leaves a lot of gaps.
So a key question that I have for you both then is there a mounting health crisis at the border?
Let me tackle that one. You know, there is, and it's been coming for a long time. We sort of turn our attention onto this crisis of the border periodically when something happens. But in the entire time of my practice as a physician, we've had a mounting problem of access, a different type of cultural population and outreach activity that we have dabbled on, and we have occasionally funded well. We have occasionally tried to interdict traffic. We have supported traffic. Lots of things have happened. One of the things that we've not done is we've not really had a consistent approach to the access of healthcare for this population. A system of integrated healthcare that allows them to have routine care, have some degree of referral, some continuity, and to provide some element of trust and security, so that this fundamental access to healthcare as a right could be honored. And so again, I see that kind of bubble into a crisis periodically. It gets a lot of attention, and then we prefer to go on to something else. We never really solve the issue.
Yeah, I would agree with that. And I think pivotal to this discussion is, what do we mean by a crisis, and a crisis to whom, right? So for the people who are living at the border day in and day out under such meager conditions, it's clearly a crisis. It's a life-threatening crisis. And for policymakers and health professionals and others who are paying attention, it's increasingly becoming a crisis, but it's one that can be mitigated against through effective policies and sufficient resources. So I think it's a crisis that can be successfully addressed.
Thanks so much for that. Essey, you mentioned something a moment ago about how citizens and organizations are getting involved and contributing to solutions at the border. I want to come back to that, but before we go there, I did want to mention to those who are on the line that we'll start doing audience Q&A here in just a couple of minutes. So we're now open for questions. I've seen a couple already come through, but just a reminder that audience members can submit their questions by either raising their blue hand, and then we'll call on you and have you ask your question verbally, or you can type your question into the Q&A or the chat box to our panelists, and we'll make sure that everyone sees what you have to say. So while our questions continue populating, I'm curious to know, Essey, let's revisit that topic. How can individuals and civil society organizations contribute to achieving health equity within the US, either at the border or otherwise?
Yeah, that's such an important question. I mean, without that solution action-oriented question, this would be a very dismal conversation. So thank you for asking that. I think the name of the game here for immigrants within the US is vaccination dissemination and meeting basic needs like food and housing. And so I'll go over 4 areas for actions that individuals or organizations can take, and then I'll talk a little bit more about how it would apply to an individual versus an organization. I think the core actions are, 1, to support organizations that provide services to asylum seekers. Again, because of the way the laws and the regulations and so forth are written, unauthorized individuals do not have access to most health and human service programs or benefits. And so they're relying on the community or these few organizations that specifically serve asylum seekers. 2, there is a huge need to build linkages between health centers, whether they're community health centers or university hospitals or what have you, with faith-based groups and ethnic community-based organizations. The health organizations clearly have the expertise and the capacity to disseminate vaccinations, but it's those local faith and ethnic community organizations that have the trust of the community in order for the vaccine to become a vaccination. Thirdly, I think that anyone who's interested in helping in this matter can invest in communication platforms for ethnic communities. For example, TV stations or radio shows or even print newspaper, if anyone reads print anymore, social media and the like. But the key is that it's culturally relevant and the language is in one that's accepted by the community, as well as having trusted messengers. And then finally, the 4th course of action to take in order to address this is to get creative and develop mobile clinics or other dissemination plans that address barriers like transportation, or have logistical designs like having vaccines administered at meatpacking plants or other large employment centers. In terms of, I'll turn now to individuals and organizations and the difference. Individuals can meet any of these 4 actions by volunteering as interpreters, helping to schedule appointments for vaccinations, delivering food assistance, volunteering their time. Some individuals in the community working in partnership with asylum seeking organizations that serve asylum seekers, have even provided temporary housing by opening up their homes to these individuals. And so there's a lot that goes into that. And then finally, individuals can donate, whether it's food or cash or whatever, to organizations. Organizations, on the other hand, have the opportunity to partner with faith-based and ethnic community-based organizations for the reasons I listed before. They also have the opportunity to fund organizations in order to amp up their staffing, their logistical planning, for example, vaccines at jobs, and also to support those communication platforms that I mentioned. So those are just a few ideas, certainly not the whole universe of what's possible.
All right. Scott, I really want to talk to you about vaccine diplomacy, but I recognize that that's maybe a slightly different topic and could take us on a whole other conversation. So I'm wondering if you have anything quick to say about that, and then I really want to get to Q&A because I'm seeing this all populating as well.
Gotcha. Let me just mention this briefly because vaccine is a huge heated topic as we move around the world. It is pretty clear that only a certain number of countries manufacture vaccine, and usually they allow that vaccine to be used in their country first. And vaccine gets intertwined quickly into foreign policy of all nations, and in terms of trying to have influence, trying to get entree for your markets and so forth. And we see that playing out where vaccine isn't really always going to where the most need is. It's going to allies, friends, and so forth as different countries vie for power throughout the world. So that without a policy that's really based on humanitarian needs and equity, you're really going to cut really far from the humanitarian imperative when it comes to vaccine diplomacy. So keep your eye out on that. As you see things unfold, we have issues of pricing, we have issues of access, we have priorities. Some countries are considered extremely valuable by third countries for one reason or another. It may be because they have mineral deposits and oil and so forth. So that the whole issue of equity and justice plays out on the world stage just like it does right at the local community. Thank you.
Well, potentially related question from the audience. Our first question is from Yesenia Vargas. Hi, Yessie. Her question is on how access to the vaccine will be distributed within lower income communities. We've already seen people go to lower income zip codes to jump the line for vaccines. Do you see this potentially happening on an international scale?
Well, first of all, I'll take this one. Vaccine, jumping the line internationally, I see countries with resources quickly getting contracts with vaccine companies all over the world. And part of the activities with COVAX and the humanitarian buffer and so forth is to reserve part of that for other countries that really have need but don't have the resources. So that we'll keep our eye on that. But it's a fact of life that there's a lot of pressure from those who have resources to get in line first. And part of the work with groups like International Medical Corps, World Health Organization, Red Cross, and you name 1,000 different intergovernmental organizations. We're working to keep that humanitarian buffer moving in so we can get the largest group where the need is. And that's moving along. Over.
All right, we'll volley over to a question about policy. And Essey, I'll direct this one at you. Scott, of course, feel free to jump in. And this one's detailed, so give me just a second. It's from Seth Stoddard. And he says, currently there are restrictions on non-essential land border crossings going both directions across the U.S. Mexico border and the U.S. Canada border. However, these restrictions do not prevent movement of cross-border trade, essential movements, or air travel. In addition, the CDC under Title 42 has restricted the entry of undocumented persons across the U.S. Mexico land border, with the main justification to protect CBP ICE officers encountering undocumented persons in quote unquote congregate settings. Have these restrictions been effective in preventing the cross-border spread of COVID-19? And should they be lifted and or revised? If so, in what way?
Yeah, that is a detailed and complicated question. I can tell that some thought has been given to that. It's a very important question. I think on a national level, it hasn't been answered yet. That's what the pressure is. To my knowledge, there isn't data or evidence that shows it is effective. In fact, depending on who you speak to, some would say that it was put in place as kind of a cover, using the pandemic as an excuse to stop migration flows on the southern border, and as was noted in the question, the northern border as well. To me, the main question is what safety precautions can be taken, both for people crossing into the US, people in detention, including the staff there. I think another important question is what is going to be the safety of the community, the public, and that's what the Biden-Harris administration has to balance.
Thank you. Our next question. Oh, did you want to weigh in, Scott? Go ahead.
Yeah, let me add something. I meant to talk about, add on something about people jumping the line in minority communities and so forth. And that does happen, but I think the distribution of vaccine, I've been down at the grassroots where it's been being implemented. There's a tremendous effort to make it fair and equitable in every way. And that is not my worry about people jumping the line. In fact, having people hanging around to the end of the day for leftover vaccine who might use it has turned out to be a way to prevent wastage of vaccines. So, but here's my worry is that in some surveys, 40% of the people in minority communities said they were not going to be vaccinated. There was some lack of trust. There was some sense that they weren't needed, that the vaccine might not be as safe as it needs to be and so forth. And then breaking down this vaccine hesitancy and while at the same time offering it to communities at risk seem to go hand in hand.
And if I may build on that, as an immigrant myself who came as a child to the US and as an African-American woman, that vaccine hesitancy has a lot to do with the history in the US about how people of color basically have been experimented upon by some in the medical field. So the same point I made earlier about the promotora model, the trusted messengers and the community health workers and navigators would apply to African-American communities and other ethnic racial minority groups.
Let me add on that because I'm bursting at the seams because she's got me going. One of the things that always worried me was the big coliseums where they gather everybody and tell them to get in line and try to do thousands and thousands and thousands of vaccines a day. That certainly has its place, but if you want to get things into the community, you have to use these trusted messengers. You have to use people, groups, clinics, and hospitals positioned in the community if you want to get out to where the people actually reside. And that we see that playing out. The time for coliseums is over. We're moving into the community level approach for vaccination at this time. Thank you.
Thanks so much for that. I love the questions that prompt that kind of back and forth. So by all means, get fired up. The next question that we have is from Stephen Jarokowski. I apologize if I just did not say that correctly. But hi, Stephen, thanks for writing in. If the California and UK strain were to merge, creating the quote unquote nightmare scenario, how will it affect the US economy, society, and US Mexico relations?
I'll take that one. There are probably several hundred strains by now of the vaccine, the virus, COVID-19 virus that is circulating, and these it will continue to be an unstable virus. I think more importantly is to ensure that the current vaccine that we have seems to continue to be effective, and that while we have concerns that the vaccine may need to be changed or modified in the future, that may be true. But at this time, what we're seeing where the rubber meets the road, we're seeing the vaccine is looking like it's effective. In other words, as the report month by month comes in, it seems to be that even though these new strains emerge, come and go, that by and large, the vaccines that we have out seem to be effective. It's not impossible that there will be a new strain, or we'll have to adapt in the future. And it may be that on a global basis, we'll change up the vaccine like we do for influenza every year, slightly to make it more effective and so forth. But effective in terms of the real test is where the rubber meets the road, and that's when it's into populations and we begin to see a decrease. And that's what we're seeing now.
All right, our next question is from Cesar Corona. We're going to see if we can get him to ask his question aloud to you both. Cesar? One moment, he's still muted. Okay, I'm going to go ahead and ask it. Sorry about that, folks. Let me just take a look here. On the topic of Mexico, there have been cases where government offices deny COVID-19 vaccines to foreigners. Are embassies or consulates advocating for vaccines for their citizens abroad?
I don't have any information on that, but would happy to look into it and get back to the questioner.
Yeah, I don't either. I was just thinking, I haven't been tracking what embassies are recommending abroad.
It would be interesting to look here, I think, locally as well, since we have, I think the largest congregation outside of DC in Los Angeles of consulates and things like that. Cesar, let's follow up on that. One more question from the audience. As we look to the future, what opportunities do you see for collaboration between the US and Mexico as we vaccinate our binational populations at the border?
I can start. Oh, go ahead.
No.
Yeah, I'm happy to start us off and just share some broad thinking. I mean, Scott earlier mentioned the many opportunities to partner between Mexico and the US, from immigration to health to trade. And I think, coming with the approach of equity and humanity and balancing the needs of different communities, there's an opportunity to coordinate, to share resources, to share planning, and to communicate with greater trust between the countries in order to arrive at workable solutions that meet the pressing needs of the people at the border.
That'll be good. Let me chime in and add to that you really got me going now. It is really time to, and I hope that as a result of this COVID, that we reinvigorate the border health initiatives. Those were a series of activities that unfolded on both sides of the border. They began to look at the population as one population, and began to tackle issues that were ubiquitous in that region. And this region extended on both sides of the border. They had cooperation of governments at the local level and at the state level. And they had ambitious agendas for 2020 and so forth, dealing with chronic disease, communicable disease, access, and so forth. Those have sort of waned with time, but I think it's clear now with COVID that, there's a big payoff from this type of collaboration. And I think that we'll see reinvigoration of the border health agenda. We will see resources. We will see a comprehensive agenda. And let me get back to this thing on equity and humanity and so forth. We've had policies in the past that are really predicated on how many dollars there are. And when the dollars run out, the healthcare ends or begins to diminish. It's not maybe the best framework, but it is a framework. A better framework really is if you're underpinned on humanity, equity, justice for healthcare access, you're going to have a much better framework to build on in the long term. And you'll be able to make better reasoned decisions on access and programs and so forth. Over.
All right, well, it looks like we've exhausted this round of audience questions, and I think we all might need a breather before doing a second round. So I think we should probably end our conversation here. Do either of you have any wrap-up comments to make?
Yeah, I just want to reiterate my gratitude for the Pacific Council for creating this platform so that this rich discussion can happen and people can think about what role they can play in order to take action. The issues that we've talked about are not new and they're not going away immediately. It's going to take a lot of work and a lot of time. And so I'm really thrilled at the possibility of having several people through their formal jobs, through their informal private lives, finding ways to contribute to solutions. So Nastasha and others at Pacific Council, thank you so much.
Yeah, this is Scott. I'd like to reiterate that. Thanks again from International Medical Corps to Pacific Council for including us. And I want to leave people with just a little tincture of hope that COVID we're going to get through this. The second thing is that I am buoyed up from the fact that what I see at the local level when I go into southern part of Los Angeles and look at the grassroots organizations beginning to tackle COVID with vaccine, outreach, consistent care, trusted messengers, I see the right pieces starting to fall into place. And I don't see that a lot of other places. So my hat's off to LA.
Well, we appreciate you both for being here and for the kind words, both for the council and for our beloved city. You're welcome back anytime. So thank you so much. To those who listened in today, thank you as well. We hope you enjoyed this topic. We're going to continue our conversation on Mexico and on health, and to the degree that we can converge the two, we want to continue to do that as well. If you're interested in learning more about the Pacific Council's work on either of these topics or other local to global issues, visit our website at pacificcouncil.org or contact me or another staff member, and we can, we'll get fired up about those things. So have a great rest of your week, everyone. And thanks again for joining us. Talk to you soon.